like I'll be mainly discussing on X-rays in ICU and I'll be showing relevant CTs. So since this is a workshop, I request everyone to participate so we can have one-on-one interaction with every case I show. Okay, so please volunteer yourself. So I'll start off with lines and tubes in ICU. So what we can see over here is the red one is endotracheal tube, the green one is Ryle's tube, yellow one on the left side is a subclavian line, and white one IJV, and the yellow one, no, it's a Swansgan's catheter. I'll be showing you. Okay. So basic anatomy, we all have learned that right side of our body is the venous side and the left side is the arterial side. Okay. So we can see here the IJV and the subclavian joins to form brachiocephalic vein, and on the both the sides, and the left and the right brachiocephalic vein joins to form SVC. So where should a central venous catheter be there? Anyone please volunteer? What is the ideal location where the tip of the central venous catheter should be there?
The junction of SVC and RM.
Yeah, it should neither be inside, too much inside the right atrium, and nor it should be high up in the SVC. So what happens if it goes too much into the right atrium? It will cause arrhythmia, it can cause even myocardial damage, it can cause even tamponade. And if it's too much high up in the SVC, then what is the risk? There's a very high risk of thrombosis. Okay. So on the right side,
Use the cursor, you can use the cursor. You don't have the point there, so you can.
how can I use a cursor? Cursor to asana. Anyways, so on the right side we can see the yellow one on the top is where the azygous vein drains, and below there is a deflection from where the aorta and the right atrium gets deflected. So what is PIC? Peripherally inserted central venous catheter. So what we do in this case is from the antecubital route, either from the basilic or cephalic vein, it goes into the central venous system. So it can be kept even for months together. Okay. So here we can see on the right hand side, it is coming from the right arm and it is going to the central venous system. So this is a zoomed picture. Inflection point, which I was talking about, is the junction where the SVC and the right atrium, there's a junction over there. So another way to detect the junction is the bronchus intermedius. What is bronchus intermedius? After carina, where the right bronchus starts and the left bronchus starts, and after the right upper lobe division goes away, we are left out with the left bronchus intermedius. So the where the bronchus intermedius intersects with the mediastinum is where the SVC and the right atrium junction is. So here we can see central venous catheter. Can anyone volunteer? Is this an IJV or subclavian vein? Why do you say so? So this is the diagram. So our landmark for subclavian vein is below clavicle, and the one which is entering from the neck is IJV. Okay. So I'm going to that slide again. So this is below the clavicle. So this is a subclavian line. So is it at the right position? What would you like to do? Is this at the right position? No. So you would like to withdraw a bit because it's more inside the right atrium. Why would you like to withdraw? Because this is an inspiratory film. This is a good film because we are able to see a lot of lung field. When we are taking a deep inspiration, the catheter goes a bit up, and when you're expiring, the catheter will go further inside, so it will cause more damage to the myocardium. So we have to be very careful. So this is a type of tunnel catheter. it is placed under the skin before it enters, where you can see the kink at neck is where it is entering the vein, and previous to that is the portion which remains inside the subcutaneous tissue. So there is this is a zoom picture. The circled one is the one where you can see that there's a cuff in a place to keep it in the position. This lies in the subcut plane, okay? And we can see the tip is at the correct position where there is a deflection, the SVC and the right atrium deflection. So the next one, this is a chest port. This is a modality of central venous catheter we mostly employ in patients who are receiving chemotherapy on daily basis. So this is a left side tunnel, and we also have a left side tunnel catheter not crossing the midline, so it stays on the left side. So what I said when I started giving lecture on central venous catheter systems. So right side of our body is our venous side, right? Left side is the arterial side. Okay. So what is going on over here? Can anyone comment what I want to say? So there is a tunnel, see there is a chemo port on the right side which looks like it's in the appropriate position. And there is also a tunnel catheter. Where is it entering? Right side of the left side of the body, right? So is it entering the venous system? So it seems like it is entering into the arterial system. Okay. So how would you like to confirm that? There are two ways. We all are doing central lines every day in our ICU. Okay. When we are inserting, we see if the patient is, I'm assuming the patient is not in shock. What will happen? Yeah, there will be a gush of blood. That's one way. Other way, we can do an ABG from both the things and we look for PaO2. So if it's in the arterial system, the PaO2 will be normal, corroborating what the saturation we are getting. And if it's less, then definitely it's in the venous system. So let me tell you, this was not in the arterial system. This was in the venous system only. So this patient had an anomaly. This patient also had an SVC, duplicate SVC on the left side. So the ABG so this could look like we have done the central line in the arterial system, but this is the way we can confirm. Okay. So this is the patient having the central venous. This is a tunnel catheter which is there high up in the SVC. So as I have told you, there's a high risk of thrombosis. We need to withdraw. We need to push inside a bit. And this is very much deep inside right atrium, so we need to withdraw. And after withdrawing, it's there in the proper position. So here is another X-ray. We can see on the right side, which line is it? The line over on the right side, it is crossing the midline instead of staying on the right side. So it has entered into arterial system. So there is no confusion over in this picture. So now what is going on? If you see a kink at that level, when you have done a central line, what do you expect? So that's the position where azygous vein starts. So we have inadvertently, since it's a blind procedure, we have entered into the azygous vein. Would you like to keep it? Because you are entering in the venous system, would you like to keep it or would you like to remove it? Yeah, because there is a high risk of thrombosis. It's a small caliber vein compared to SVC, so we'd like to withdraw it. And this is a pic showing this curved, it is curved at its tip at the same level as we can see in the left. So this is also there at the azygous vein. Okay. So this is another X-ray which is showing the pic has coiled at the neck level itself. And instead of going caudally, this has gone cranially. So this also needs to be removed. Okay. So what happened here? I hope you are able to make out. I don't know how it's being projected from the distance. So what's black on X-ray on CT? Air, air and air. Okay. So what we can see, if you compare the left hemithorax with the right hemithorax, we can see after doing a subclavian line, The patient has had a left pneumothorax. Okay. So sometimes when you do a chest X-ray in the ICU, many a times the patient, the position of the X-ray being done is supine rather than sitting or sitting upright. So sometimes even a small pneumothorax can be missed. So we can see a very important, which I'll be discussing anyway later. So there's a deep sulcus. If you compare the sulcus, the costophrenetic angle on the left side, there's a deep sulcus and there are no lung markings which can be made on the left side compared to the right side. So there's a definitely pneumothorax. It should not be ignored. We have to go ahead with the chest and immediately. So can anyone volunteer what has happened over here? This is the before central line and the after central line. The X-ray done 1 hour after the central line done from the left side. Anything obvious? Yeah, somebody said. Yeah, there's a mediastinal widening. So the patient had a mediastinal hematoma. So this is another case. Line has been placed for IV construct. The patient we had to do a contrast study of the CT. So the peripheral access could not be done. So hence the line was done. So where exactly is the line? It's there in the correct position. The first picture. Looks like it was there too much inside. Yeah, then it was withdrawn. Okay. So does it still look like it's there in the normal position? Pardon? Okay. But then look at the tip of the X-ray. It's looking like it's towards the outward, isn't it? Doesn't really happen like that. But still, nobody was sure. Nobody can actually comment further where exactly it is. So anyway, the patient went ahead with the CT scan. So after the contrast, something happened. So after contrast was given, everything spilled into the pleural cavity. So basically it was lying in the pleural cavity. So when you are not sure, we might have to go for CT scan just for confirmation. So we can see a bit of air also. It was a hydropneumothorax. You can see there's an air over there. Okay. So coming to the Swan-Ganz catheter. Okay. The introduction is done the same way the central line is done, and it goes first into the SVC, then right atrium, right ventricle, then main pulmonary artery, and either right or left pulmonary artery. So where the we measure the pulmonary capillary wedge pressure is checked over there. So this is how it is traced. Okay. So ideally, the tip of the Swan-Ganz catheter should not cross medial and middle third of the lung field. So like if we divide the hemithorax into the 3 halves, as you can see in the lowermost portion, for medial half, middle half and lateral half. So it should ideally be somewhat between in the medial half of the lung field. So if it goes too much into the smaller branches, like if it goes more laterally, what will happen when you inflate the balloon to measure the pressure? It will cause damage to the vessel. There might be rupture and there might be an infarction. Okay. Next. So can we trace is it visible? The air column, trachea dividing into left and right bronchus. So we have an endotracheal, can we see the radio opaque endotracheal tube? So what is the ideal position of where should the endotracheal tube should lie? Fine. Approximately 5 centimeters from the carina. Okay. So in most of the individuals, the carina is located between the levels of 5th and 7th thoracic vertebrae. Okay. So I'll show you cases and then we'll discuss. So what has I hope the endotracheal tube is visible over here. Yeah. So what happened over here? It is there very high up. So there might be a inadvertent extubation, self-extubation is possible if it's there enough. I hope it's visible in the midline. Okay. So even in such cases, what happened is if we flex our neck, it goes more 2 centimeter inside, and if we extend our neck, it goes 2 centimeter above. So we have to be very careful. So that is the main problem with the endotracheal tube. Mind you, when a tracheostomy is done, it has got no relation with flexion and extension of the neck because it's below. It does not affect. Okay. So this is what I was talking about. In neutral position, what is the neutral position of the neck? The mandible. This is the mandible. Mandible should lie at the level of cervical spine. So now coming to this is a very important X-ray. We should all be very careful. What has gone wrong over in this X-ray? Somebody has intubated in the emergency and patient is not maintaining saturation. So this is a clinical history of this patient. Can anyone please volunteer? Yeah. So what has happened? We can see endotracheal tube at the neck level. This is where it's lying, and in the center we can see the air column. So it's the endotracheal tube is lying outside the airway. Okay. So what are the other points we can see? The patient has also undergone a Riles tube insertion. We can see the endotracheal tube is almost parallel to the Riles tube. And any other point, but it's very non-specific. We can see a lot of air inside the stomach. So anyway, if the patient has received lot of ambu, then also there will be a lot of gas inside the stomach. But we have to see whether it's lying in the proper position also. That's what. So what happened over here? Yeah, this is one lung intubation. So it has gone too much into the over the right mainstem bronchus. So we have to withdraw a bit. Otherwise, the patient will not be able to maintain. What happens if I keep the patient like this for next 1 or 2 hours, or maybe I have not noticed. Somehow the patient is maintaining saturation. What will happen is that there will be a too much collapse, and there might be again a barotrauma and pneumothorax might happen on top of the collapse. Okay, so the pointed arrow. So I have already told you, we are dealing with, in this session, only 3 colors. Black, grey and white. So too much black is what? Air. So what is happening over here? The pointed arrow, you have your answer in front of you. No. Can you see the shape of the marking? The shape, can you make out the black area where I have put a pointer? It's round in shape. And what is over there? Basically, there's an endotracheal tube. The cuff has been inflated too much. So you have to look for that also. If you have inflated too much air into the balloon, it will cause damage. So that is also visible over in this X-ray, right? So hyperinflated endotracheal cuff more than 1.5 times the tracheal diameter. Tracheal injury like rupture, tracheomalacia, or even stenosis can happen. Okay. So this is a tracheostomy I have told. So the what is the exact position where the tracheostomy tube should lie? From the stoma to the carina, and there is a tip of the tracheostomy in between. So it should be approximately the midway between, the tip should lie almost midway between the stoma and the carina. So coming to the next topic, what one can see over here? I've already discussed hydropneumothorax. What would you like to do? ICD. So we have done ICD. Okay. So this is like half an hour after ICD. After putting in ICD, patient saturation is dropping. Would you like to repeat an X-ray? Okay, we repeated an X-ray. What is this? Hydropneumothorax, we have put chest drain on the left side. After putting a chest drain, what has happened? No. Lung markings are visible on the right side. What has happened on the left side? Sometimes, if there is a huge pneumothorax which put a chest drain, sometimes there might be a re-expansion pulmonary edema. So we have to keep this thing in our mind. So it's like more of a unilateral phenomena rather than the bilateral pulmonary edema which we get. Okay. So tell me what's wrong with this. What would you like to do? What is the basic pathology we are dealing with over here? Pleural effusion. Fine. Either we can, if we get such a massive effusion, what we would like to do? Either we aspirate, simple aspiration, or we put a chest drain. Okay, so we are dealing with the lines and tubes over here. So where is the tube? Where is the tube? Can you make out the tip of the tube? Where is the tip of the tube lying? It's lying in the subcutaneous plane. It's outside the pleural cavity. So somehow, sometimes if we do not put the stitch properly and the patient coughs, the stitch comes off and it lies in the subcutaneous plane basically. Okay. So there is there's a kinking over there. So we need to withdraw the chest tube and a bit, and we can see a lot of subcutaneous emphysema also. Okay. What is this? Rice tube. I'm just skipping this. What has happened? Forceful rice tube insertion. There was a fracture on the nasal plate and it has gone up. Okay. So now this is pacemakers, permanent pacemakers and implantable cardioverter defibrillator, ICDs. Okay. So can you please tell me how to differentiate between the two? This ICDs have got shock coil. There is a more opaque lines you can see. Can you make out? These will be there only in the ICDs, not in the permanent pacemaker. So that's how you can radiology make out. And the machines, the generators will be a bigger in size, although the new generations are becoming a bit smaller. But really, if you compare the size of the permanent pacemaker generators and ICDs, the machines are a bit bigger for ICDs. So what is opened here over here? The atrial lead should be there in the right atrium. Okay. But it is lying in the SVC on the left picture. And can you look at the tip of the ventricular lead on the second? It's lying outside. So luckily that still the patient has not developed tamponade, but it can happen any moment. So it has pierced the ventricles and gone out. So this is another extra. Can you look at the pointed arrows on the left and the right? So there was a thinning. There was an incomplete fracture of the atrial leads on the left side. But after a few years, a repeat X-ray was done. It showed that the lead has completely dislodged. So this is an intra-aortic balloon pump. Many a times it's used in cardiogenic shock. Okay. So there's the tip of the there's a radiopaque marker at the tip. So if you see something like that in the descending aorta, so that's intra-aortic balloon pump. So I'll go a bit fast now, so because we don't have much time. Parenchymal disease. So this is how lobar anatomy looks. On the right side there's a horizontal fissure and oblique fissure, and there's only an oblique fissure on the left side. So right upper pathology, right middle lobe pathology, right lower lobe pathology, and this is how a left upper lobe, it covers a lot of area. Okay. So Silhouette sign, let me stop over here. What is a Silhouette sign? Can anyone say? Okay, fine. Imagine a normal X-ray. Did it ever occur to you why in the middle there is a heart and beyond heart there are lung? So if we consider the heart and lung border, heart is white in color and lung is black in color. So there is always a sharp border. if the X-ray is normal. Okay, so why there is a sharp border? Because the density of the lung is different, and there is a density of the heart, and the mediastinal structure is different. So if I keep something adjacent to the heart border, which is of the same density as that of heart, then can we make the border? Can we make out any difference? Can we make out, it will the border will be gone. So that is called silhouette sign. Okay. So what helps? These days we are doing a lot of CTs, but it was not there. Like CTs being ordered were not very frequent even in, like 10 years ago. So silhouette sign helps us in localizing the location of the pathology. Okay. So there's a chart. Right upper lobe corresponds to the ascending. If there is any lesion adjacent to the ascending aorta, then the pathology is in the right upper lobe. Right middle lobe corresponds with the right heart border. Right lower lobe with the diaphragm. Okay. So I think after I show the X-rays, it will be more clear. So in this X-ray, can you please mention in which lobe is there is pathology? Right now, because the right heart border is very fuzzy, right? So this is in the RML, right middle lobe. This one? Pardon? Why do you say lingula? You have to justify now.
Because it is in the left lobe. Sorry, left lung.
Huh? It's there in the left lung, fine.
There is no middle lobe in the left lung.
Okay, but can you see the left heart border? Is it prominent or is it not prominent? Border is visible, right? Okay, so it's not there in lingula. Pardon? Left upper lobe. No. Can you make out the aortic knob?
Yes.
It's visible. So we are left out with left lower lobe. Okay, because sometimes left lower lobe is quite huge. It covers a lot of area. Okay, so descending aorta is not visible that much. So by excluding other things, we can say this is there in the left lower lobe. Now this one, this is there in lingula. And this one, the last one, is the diaphragm border visible? Left lower lobe, fine. Okay. There's something called a spine sign. There's a paradoxical increased density of lower spine in lateral X-ray. So if we get so much of increased density, so at this paraspinal region in the lateral X-ray, though we can say that it's there in the lower lobe, but right or left we cannot say in this X-ray. What is air bronchogram? So I'll stop over here. So pneumonia is an air space disorder. So the what is happening is alveoli are getting filled up with exudates and proteinaceous material. Okay. So why is this air bronchogram happening? Yeah, patent bronching is there. What happens is, suppose there are 3 bronchi and alveoli. Number 1 is getting filled with material. Number 2 is not getting filled with material. Number 3 is getting filled with material. So the first and third is filled with material, but the middle one is not getting filled with material. What does the middle one have? Air. What is black in X-rays? Air. So if there is non-uniform distribution of the proteinaceous material in the alveoli and airway, and then if there are certain airways which are not filled up, which still have got air inside them, due to that we'll get air bronchograms, which are very specific for pneumonias. Okay. So I'll skip this table. I'll go to the X-rays directly. So where is this happening? This is a type of pneumonia. This is lobar pneumonia. It's involving right upper lobe. Okay. This one. What is this pattern called? bit more, it's called bronchopneumonia because there are, it's like a filling defect as I have told you to, but it has not extensively involved as in case of lobar pneumonia. So what happens is in lobar pneumonia there is a homogeneous consolidation, but in segmental or bronchopneumonia there is patchy. Okay, air bronchograms are more common in lobar pneumonia, and there are sharp borders corresponding to the anatomical area, which is not there in case of bronchopneumonia. Reticular pattern, which is you were talking about, is involvement of interstitium. The infection starts with the interstitium, which can gradually progress to bronchopneumonia and even cause lobar pneumonia if there is extensive involvement. So this interstitial pattern is more specific for atypical pneumonia like mycoplasma, chlamydia, even viral pneumonias can cause such presentation. So sometimes there can be a round pneumonia and sometimes we can get cavities. Okay, so if you think of cavity, first thing which you have to keep in mind in India is tuberculosis. Okay, so this is aspiration. If we get such infiltrates in the dependent areas, we always have to think about aspiration. What is this sign called as? MCQ? Yeah, this is bulging fixation sign. Specific for? Not always, but it's a book teaching that you might get in Klebsiella. Left side, what is going on in the right lower zone? It's a huge pneumonia which is undergoing necrosis. So this is necrotizing pneumonia. And on the right side, there is an air fluid level. There's a big pneumonia, big patch which is undergoing a necrosis, and now there is an air fluid level. So this is lung abscess. Very classical X-ray. Miliary mottling. Fine. So what is the criteria for calling it a miliary mottling? Less than 2 millimeter in size. Okay. So we can have a very many causes for miliary mottling, most commonly being miliary TB. Okay. Even a metastasis from organs like thyroid, kidney and sarcomas can also cause similar picture. We have to assess and further see. So this is a very classical X-ray, nothing related to ICU. This is a very historical picture. I have put just for interest sake. So what is, does anyone know what is this? No. I am talking about pre 1940s or 1950s, I guess.
The type of treatment for TB.
Yeah. Please, you let them speak. Okay, this is called as plombage. Okay, plombage is a plombage is a word which has come from plumbum. So what is plumbum in chemistry? We have learned lead. So there were lead balls, or in this specific thing called as lucite balls. Okay. So what happens? What is the most common site of tuberculosis? Apex of the lungs. Okay. So previously, when there were no drugs for TB, they used to think if they put something inside the lung and collapse the cavity, it will heal the lesion. So that's why these operations used to be done. They used to put lot of lucite balls inside the cavity, and they used to make the cavity collapse. So plombage, lucite balls, and what happened was you can see some of the lucite balls are filled with material. So these lucite balls are infected, we can see in the CT. So this is how it looked like. Okay. What is this? This is CT. Any particular pattern you can think of? You can see a lot of reports these days of these type of pattern. I'm giving you a clue. This is very much suggestive of tuberculosis in India. But this is not specific for TB. This is tree in bud. Can you make out? There are a lot of tree branches and there are buds at the end. So this is a very classical picture of tree in bud. So we generally get, whenever we get tree in bud, we think of tuberculosis. What is going on over here? So this is an HIV positive patient. 3 months duration of fever, now has landed up in hospital with breathlessness. Fine. So it looks like more of an pulmonary edema. Okay. So sometimes we might get cysts, and this cyst can even cause pneumothorax. So if we get such clinical presentation, we always have to think of PCP or PJP now is the term, pneumocystis jirovecii pneumonia. So these three pictures have got some connection. Okay. This is the triangular. Pardon? Someone said? Yeah. That's Hampton's hum. And this one? Not very visible, I think, in the projection. Westermarck. What is Westermarck sign? Fine, I'll tell you. So the basic reasons for all these three lesions is only embolism. What does the embolus do? It obstructs the pulmonary artery, and distal to the embolus there is no blood flow. Fine. So that is called infarct, pleural based infarct. And Westermarck sign is what? Since there is no flow distal to the embolus, there is focal oligemia. It looks more, that particular area looks more black. That is Westermarck sign. And what is Fleschner's sign? Since there is raised pulmonary artery pressure, the hilum becomes more prominent. Okay, so what can we see over here? Lot of rounds and rounds and rounds. So there are lot of round opacities, cavitating or lot of cavitating opacity. I'll give you a little bit of history. He's an 18-year-old gentleman. Lot of drug. He's into IV drug abuse. Okay. Yes, landed up with high grade fever in your ICU, not subsiding with co-amoxiclav treated on the OPD basis. Now he's desaturating. So what do you will think of? Staph is the etiology, but what are we dealing with? I have put the CT also. Okay. So what we can see in the CT, it is called as feeding vessel sign. Can you make out there are vessels which are entering into the lesions? Is it visible? So this is septic embolism secondary to Staph aureus. Possibly it could be due to infective endocarditis causing septic embolus. Okay. So what does this feeding vessel sign mean? The source of the infection is hematogenous. The primary route is not lung. So it's a bloodstream infection coming via these vessels causing these problems in the lung. So the feeding vessel sign means this. So this is a very classical X-ray. Anyone? No? This is a rounded opacity and something lying inside. Two different cases. One X-ray, one CT. Same thing. Yeah, fungal ball. So it could either be mycetoma or aspergilloma. If the etiology is aspergillus, it is called aspergilloma. So there is this called as air crescent sign. We can see if there is due to some reason there is a long standing cavity, such patients can have this development of this fungal balls. So these patients are very prone to having very massive hemoptysis. These patients come with massive hemoptysis to the emergency. So which sign is this? Very sick patient admitted in ITU. X-ray done. X-ray is not very specific since the patient is not very tachypneic, not able to hold breath. He's diabetic, elderly, very poor control diabetes. What will you think of? Pardon? Yeah, absolutely. So this is halo sign. Halo signs are suggestive of, not aspergilloma, fungal infections, fungal pneumonias. Okay. What is this? When we read halo sign, after that this is the next thing which we read. Reverse halo sign. So what happened in the halo sign? I forgot to tell you. What is in CT, what is consolidation and what are GGOs? After COVID era, we have seen lot of report GGOs, consolidation, this, that. But what is actually consolidation? What is GGO? Yeah. You'll be able if you keep the newspaper below the plate, you'll just be able to read the prints. You'll just be able to. So that is GGO. And if you're not able to read anything, consolidation. So it's an evolving lesion. GGOs can become consolidation if not taken care of. Okay. So first GGOs, then consolidation. It's all about the density. So in halo sign, what is happening? Center of the, if you see the center of the lesions, it is dark. It is consolidated, and there is surrounding areas of GGOs. And opposite is in case of reverse halo. Center portion is either normal or GGO is there, and outside is there are area of consolidation. It is also known as atoll sign. Okay. It is seen in cryptogenic organizing pneumonia. It's not specific, but we can see in COVID also, in various other etiology also. Achha, what is happening? These are many X-rays evolving in since 2004 to 2007. 2004, right? Lower zone opacity. Then cleared off. Then again right lower zone opacity. Then again bilateral opacity. Then again 2006 another opacity. 2007 another recurrent. The patient comes to the GP and then he gets a course of antibiotic, does not get relief, and then this vicious cycle goes on. So what is happening? Would you like to ask me something? Would you like to take some history from me?
History of any pancreatitis or chronic pancreatitis?
No pancreatitis. No, nothing related to Arindam, you need to stop. Okay, this is not for you. So, okay, fine, let me give you. The patient is a 25-year-old gentleman having asthma who does not believe that he has got asthma. He does take inhalers irregularly whenever he ends up with exacerbation. So, the X-rays were taken whenever he had an exacerbation. So, I'll give you, what can we see over here? What can we see? So, this is related to the previous slide only. In this CT, we can see there are a lot of grape-like clusters, rounded opacities. What is that? Bronchiectasis. Is it in the central portion of the lung or the periphery? Central bronchiectasis. Okay. Can we see in the right uppermost corner, can we see there is a lesion? In the central portion of the lesion, it is whitish in color. So it is high attenuation mucus. So these all, if the patient does, pardon? No. This is a case of allergic bronchopulmonary aspergillosis. If the asthma patients do not take inhalers regularly as prescribed by the physicians, these people will land up with colonization of aspergillus. This aspergillus will cause immunological phenomena and cause destruction of the parenchyma like this. And whatever things you are seeing, this is a very famous MCQ, the upper one, middle portion, finger and glove appearance. Okay. So what is finger and glove? There is a lot of mucus impacted in the bronchus. So this is a case of ABPA. These are bronchiectasis, another case of bronchiectasis with infective changes. How do we know there are infective changes? Because in these rounded opacities, there are air fluid levels. Next case. Would anyone like to comment on the diagnosis? We have seen treen bud appearance, but this is something very close to treen bud. There are small nodules visible, but it's adjacent to the fissures. This is very classical picture of sarcoidosis. Now, this is what is this? GGO or consolidation? Both. But where is the location of these GGOs? Peripheral. We can get such CTs in COVID also, but in pre-COVID eras, we used to always think of whether any eosinophilic pneumonia is happening or not, which requires steroids rather than antibiotics. So it could be due to chronic eosinophilic pneumonia or organizing pneumonia. So, okay. So we can see a lot of rounded opacities again, which are cavitating, and the patient came with a history of epistaxis, and we can see there is a perforation. Yes. Yeah. ENT involvement and lower airway involvement with kidneys involvement. So we have to look for these three systems: ENT, lungs, airways and kidneys. And even skin manifestations can also be there. So this is the COVID-19 pneumonia we all been seeing. So lot of GGOs and consolidation. If this was a pre-COVID era, I would have thought of something called as a variety of ILD called as NSIP, non-specific interstitial pneumonia, where we get lot of ground glass opacity, minimal consolidation. This is very common X-ray we see in ICU, ARDS. So I'm not getting into the Berlin criteria. So we have completed the air filling disorders. Now we'll go to atelectasis. What is atelectasis? So in pneumonia, there was lot of material being collected inside the bronchus and alveoli. Suppose I obstruct the airway with something. Post obstruction, air will be gone and there will be volume loss of lung. So there are 4 types of atelectasis. In atelectasis, what is happening? The fissure is being dragged. Yeah, this is upper lobe collapse. This is a with this sign is called golden S sign. Okay, so if we are getting such X-ray, we have to think why the atelectasis, why the right upper lobe is getting collapsed. So we can see there is a lung mass which is causing partial obstruction. Sale sign. So this is very important X-ray when we are dealing with the patients in ICU. What is a sale sign? So if there is a left lower lobe collapse, it will not be visible much. We have to think beyond and we have to seek retrocardiac opacity. So there will be a triangular like opacity. This triangle corresponds to left lower lobe which is getting collapsed. Now this patient has come to the ICU with lot of cough and expectoration. This is day 1, this is day 2 and this is day 3. What happened? Mucus plug causing entire collapse of lungs. So the patient needs to undergo bronchoscopy with airway toileting to relieve the obstruction. So if the obstruction is happening over hours or days, would you like to think about benign pathology or malignant pathology? If this had happened over months, then I would have thought about malignant process. But if this has happened inside ICU, then we have to think about some benign cause, like either if there is a hemoptysis, we have to think about clot collapse or mucus. Now, this is compressive atelectasis due to pneumothorax. Now, this is a very frequent post-op patient. We will get such opacities and get referrals from surgeons. So, what is happening? Any upper abdominal surgery will cause decrease in the movement of diaphragm and will land up with such plate-like atelectasis. And after, if we take X-ray after deep breaths, it will be gone. So pain management, physiotherapy is the treatment for this patient. Okay. So poor inspiratory effort after post-op or decreased concentration supine patient will cause dependent atelectasis. Now this is a long-standing patient with post-TB fibrosis. This is cicatrization atelectasis. I'll go a bit fast. Blunting left costophrenic angle. We can make out a small amount of blunting on the left side. But at the same time, if this patient undergoes lateral X-ray, we can easily make that out. So at first, it fills up the posterior costophrenic. The water goes first at the posterior costophrenic angle. This is a historical X-ray. Small pleural effusion can be visible if it is done in the left lateral decubitus. And these days, more sensitive and cheap is to do USG assessment. Even 5 to 10 ml will be visible in the USG hemithorax. So this is the right side pleuration. This is the left pleuration causing massive shift in the mediastinum. Okay, so what is going on over here? This is a supine X-ray plate. There is only a right lung haziness. This is a supine X-ray. I did an upright X-ray. So what happens when you make the patient supine? The water goes like this. So always try to do X-ray in sitting position. You have to give instruction to the technician that please do the patients of my this patient's X-ray in sitting. Rather we'll be thinking about other pathologies. So this is a loculated effusion in the left lower zone, and we can see there's also an air fluid level. So this is a pneumothorax. This is also a pneumothorax. Right side is a massive tension pneumothorax. We can see the heart and the airway both have got shifted to the left side. What is this? Would you like to give a chest drain over here? Is this a pneumothorax? So this is the problem with the portable X-rays we get sometimes in our ICU. So this is a skin fold. So we have to look beyond the margin which we get. This is going to be a catastrophe if the patient party is not going to leave you if you put a chest drain over here. Okay, so we can see lung marking over beyond this point. If you're not able to get lung marking, then only you have to think of pneumothorax. If there is a confusion, go for a repeat X-ray in proper positioning. Okay. There are a lot of nodular opacities, so it could be pleural metastasis. So I'll go fast. This is pneumothorax. So over here, what is this? What would you like to do? Yeah. What would you like to do now? So this was the previous X-ray. We have given a chest drain over here, and you are saying this is a bulla. Would you like to give chest drain over here? Never. Unless a bulla is causing pneumothorax, we are not going to put. Other going to be another catastrophe over here. Okay. So how to differentiate? Convex, concave. Convex, concave. Okay. So you have to see the margin. So there is a huge bulla which is causing concavity. But in pneumothorax, there is convexity due to the collapse of the lung. So that's how we differentiate these two. So this is the deep sulcus sign I was talking about. Can you make out the marking? Whenever you are doing a portable lying down X-ray, so pneumothorax may not be visible, but this deep sulcus is very much suggestive of pneumothorax. COVID-19 pneumonia, severe disease on NIV, complaints of retrosternal chest pain. What is the diagnosis? I put lot of arrows. So those arrows are corresponding to lot of black areas. So those black areas in those areas means, yeah, pneumomediastinum. Okay, so this is a very important sign. Yeah, continuous diaphragm sign. So this is also another sign suggestive of pneumomediastinum. What do you see over here? Air everywhere. So there is a lot of subcutaneous emphysema which is producing this type of lesion. Acute epigastric pain. Gas under diaphragm, pneumoperitoneum. So visitor of thorax. So 24-year-old male came with pain abdomen with vomiting. Exam X-ray. What is this? This is a syndrome. Yeah. What happens in chilladity? Liver. Okay. So generally most of the time these patients are asymptomatic, but if they come in with pain abdomen, we need to evaluate whether any obstruction is happening or not. So this is a 59-year-old female came with breathlessness on exertion. That's it. Vital stable, nothing at all. What is the diagnosis? And what can you make out? So the gut has entered into the hemithorax. So how do we make that? We can see lot of hostrations. There are lot of colonic marking, and in CT we can see this. In CT scan there is white area corresponding to heart. There is a deep black area that is corresponding to lung, and there is some density in between, grayish areas. So these grayish areas correspond to fat areas. It means fat. Gray in CT scan means fat. So fat areas in those means mesentery. Okay. So if you get gray areas and such lesions in CT, it is nothing but mesentery or omentum. Same thing, volvulus of stomach. This is a case of achalasia cardia. Why do I say this is achalasia cardia? We can see at the top level, at the neck level, there's an air fluid level. Okay. So what does this mean? Achalasia cardia means the gastroesophageal junction is not able to relax properly. So there's a lot of food going, but it's not going down. So fluid is accumulating and it is causing an air fluid level inside the esophagus. So this food particle and the air level is causing air fluid level. So what is going on over here? There's an air fluid level behind heart. So this is a case of hiatus hernia. So bone or not bone? Admitted in ICU with post CABG, this is an incidental finding. Can you see there are a lot of calcified areas in both the parenchyma? This is a very classical X-ray of asbestos exposure. This is called holy leaf sign. This is just an incidental finding. But this patient, 80-year-old male, breathlessness for 5 years progressive, shipyard worker. So shipyard worker means he also has got exposure to asbestos. So can you make out there are a lot of, there's a calcified sheet like thing. So this is a pleural calcification, not parenchymal. If you see something like white line like that, say on that side and this side, those areas are there in the pleura, not in the lung parenchyma. Okay. So this is an asbestosis with pleural calcification. So what is asbestosis? Asbestosis is involvement of the interstitium. If the interstitium is involved, then we quote all the osis, silicosis, asbestosis, pneumoconiosis. Unless the interstitium is involved, we cannot call them as asbestosis. So this is another X-ray, but this is post-tubercular fibrothorax with pleural calcification. Now this is another incidental finding. Patient came with failure to the ICU, but he has got lot of calcification, especially in the central areas, mediastinal areas. So this is eggshell calcification. Now this is a very rare, very rare X-ray. So what? So much of whiteness in lung parenchyma means what? Calcification. So this is a 23-year-old female, progressive dyspnea. This patient's sister died at the age of 30 years of some pulmonary disease. So what is the diagnosis? So this is pulmonary alveolar microlithiasis. So what happened is there is a problem in the surfactant. So this there is a gene mutation of SCL34A2. Okay, so what happens is there is accumulation of phosphate inside the alveolus, and when the calcium gets deposited, this gets accumulated in alveoli. These patients generally die early without, there is no treatment for this. Now where is this calcification? Where is the calcification happening? Pericardium. So this is pericardial calcification. So these patients can come with constrictive pericarditis. What is the general presentation of constrictive pericarditis? They come with big ascites, disproportionately not much of pedal edema, okay, and breathlessness. Evaluation of GI liver comes normal in these patients. So next thing, what is this? Round like opacity, right lower zone with lot of calcification. This is hamartoma. This is popcorn calcification. Trauma case came to the emergency. Portable X-ray done. Rib fracture. So when it heals, it forms by lot of callus formation. Rib fracture causing, in such trauma patient, what we have to see? If there is an effusion with rib fracture, what we have to think of? Huh? Pardon? Hemothorax. Fine. Because if there is a hemothorax, we have to drain it. So if you are not able to understand where there is rib fracture, you can always rotate the X-ray and see like this. The rib fractures are easily made out if we rotate if we make the X-ray and see like this. So this is a case of failure. Lot of things we can see. There's a pacemaker over here. Cephalization due to lot of pulmonary edema. there's cephalization of the vessels, there's a hilar prominence, there's a full hilum, and there's curly B lines at the both the lower zone and the cardiothoracic ratio. This is very classical of congestive heart failure. Orthopnea, PND desaturation, chest X-ray detected in SOL. What would you do, FNSC or true cut biopsy? Would you like to do biopsy for this patient for diagnosis? Or would you like to do something else? Yeah, we'll give diuresis. So this is a phantom tumor. So there is an opacity, the fluid has accumulated in between the fissure which is causing an SOL like this. Now this is a classical X-ray of mitral stenosis. Double contour sign. This is a normal X-ray and this is an, we can see left, there's a double border, right heart border. So the one, upper one is a left atrium and the lower one is a right atrium. So enlarged left and right atrium. Similar sign. This is a double density sign. The inside one is the left atrium and outside is the right atrium. So which appearance is this? Water bottle sign, large pericardial effusion. Now, this history is very important. This is a 25-year-old male, hypertensive, tall fellow, retrosternal chest pain, not relieving with PPI. The patient says, and on vitals exam, it was found that there is an unequal pulse volume. BP not equal on both the sides. Coarctation or dissection aorta. Can you say what we can see in the CT? We can see the flaps. There's in the aorta, we can see there's a triangular flap coming off. Those are intimal flaps. So, what is this? What happened to the arch of aorta here? Aneurysm. So, this is a very common picture. COPD patient coming with cor pulmonale, lot of pedal edema, desaturating. So, what we can see in the X-ray is bilateral hilar prominent. Too much hilar prominence. What would you like to do? Would you like to go for an echo or CT? Yeah, we have to look for pulmonary hypertension. So the pulmonary arteries are dilated. So this is an exam X-ray, nothing to do with ICU. This is situs inversus with dextrocardia. So, this is, can anyone tell me, there is one picture on the left side and one picture on the right side. I am telling you, one of the lesion is in lung and one of the lesion is in mediastinum. Which one is in the lung and which one is in the mediastinum and why? Left one? See, I have zoomed the picture. So, generally the pulmonary lesions make an acute angle with the line. And the margins are very fuzzy. Those are not very sharp. And most of the time the pulmonary lesion will always be on one side rather than being bilateral. Whereas if it is in the mediastinum, it generally makes an obtuse angle. The margins are sharp and it could be on both the sides. Okay. So that's how we differentiate. So this is in a bilateral lesion, so it's in the mediastinum. So first thing, mediastinum or lung? It's making an obtuse angle over there. So, it's in the mediastinum. So, after we have seen where we know that this is in mediastinum, we have to look for certain things. Are blood vessels visible through these lesions? Yes or no? Blood vessels visible? Yes or no? Yes. Okay. So, if the blood vessels are visible, so definitely it's not there in the middle mediastinum. So, we are left out with either anterior or posterior. So, if the lesion is making silhouettes with right cardiac border or ascending aorta, then it is in the anterior mediastinum. So it is making a silhouette sign with ascending aorta and right. So, this is in the anterior mediastinum. So, this is another lesion. We can see there is some fullness in the aortopulmonary window. So, this is suggestive of middle mediastinum. There is a convexity. So we can see in the normal X-ray, there is a concavity below arch of aorta, okay? But here below arch of aorta, there is fullness. This is another X-ray. So can we see vessels, blood vessels through these lesions? Yes. So it's either there in anterior mediastinum or posterior mediastinum. So is it making any contact with the right heart or ascending aorta? I think right hearts are easily visible. So this is there in the posterior mediastinum. So another sign I would like to show. So there are two lesions. One lesion above clavicle. The margins are sharp or fuzzy? Which one is sharp? Right one is sharp and left one is fuzzy. Okay, so I'll tell you what is the significance of this thing. So when we are doing an X-ray, the anterior mediastinum ends at the level of clavicle and the posterior mediastinum extends above. So if you get some lesion which has got a sharp border above clavicle, then it is there in the deterioration, consider repeating the imaging, especially in the ICUs, and we should never write CT thorax like we write CBC for the patients. So we should always do CT thorax whenever it is indicated. And sometimes we restrict ourselves to the lesions we see in lung only. We have to always think about any lesions outside lung parenchyma. Thank you.
Rest of the doubts would be cleared in the workstations. May I request Dr. PR to felicitate Dr. Pratik, please?